Everybody, this is Dr. Patel. I work in Medical College of Wisconsin as an assistant professor of medicine. Today we'll be talking about approach to antibiotic uses. I have split this lecture into three parts. In the first part, we'll be talking about general approach to antibiotic uses. Let's dive into it. I'd like to start this lecture with a disclaimer that this is intended solely for education of fourth year medical student, and it is by no means intended for use as a direct source for making medical decisions. The learning objective for this presentation is we'll be talking about history of antibiotics, then we'll be talking about antibiotic resistant crisis, then we'll be talking about general framework for prescribing antibiotics, then we'll be talking about evidence-based approach to manage common infection in our lecture number 2. And in our lecture number 3, we'll be talking about major class of antibiotics with emphasis on clinical themes. Let's start with history of antibiotics. In the ancient world, we didn't have antibiotics. People tried different stuff to treat infections. Examples include application of moldy bread to the infected wound. But in last 100 years, antibiotics have changed the modern medicine. It has increased the average human life by 23 years. It all started with Paul Ehrlich in 1909, who discovered salvarsan, which was used for the treatment of syphilis. Then Prontosil was discovered by Gerhard Domhack. He actually used it to save his daughter's arm, and it was one of the first sulfonamide. And in fact, sulfonamide was the first truly effective antimicrobials. But these were antimicrobial. These were not fancy. People are talking about antibiotics. Antibiotics were defined as a compound made from a microbe which is used to destroy another microbe. People are doing research on that. In the meantime, in 1928, Alexander Fleming, he was studying Staph aureus, and it was around August and early September when he decided to go for vacation. He was in such a hurry that he left all those staph colonies everywhere in his lab. And when he came back, he found that his staph culture were destroyed by contaminated water. So the contaminated cultures were destroyed, as you can see here, but the colonies which are far away, those were intact. So it didn't take him long time to speculate that there is something in that dripping water that is suppressing the growth. And he was able to isolate Penicillium notatum from the culture. So that's how, antibiotic started. Then, in terms of regulation, there was a fire in Boston in 1942. And then what people did was, they used penicillin in the treatment of skin graft infection secondary to staph at that time. And that was a, landmark event that compelled U.S. government to begin supporting the mass production of the drug. Then in 1944, penicillin was widely used to treat troops. And by the end of the World War, it was named, wonder drug because it saved millions of lives. Then Fleming collaborated with two other scientists, Florey and Chain, to develop the mass production of antibiotics. And in 1945, all these three people were awarded Nobel Prize. When you talk about antibiotics, you cannot forget Selman Waxman, who started systematic study of microbe as a producer of antimicrobial compound. He started that in late 1930s. He identified actinomycetes. If you can see here, actinomycin is responsible for so many antibiotics which we use now. In 1952, he was awarded Nobel Prize for the discovery of streptomycin, the only drug against tuberculosis at that time. But the rapid and relatively easy discovery of multiple class of antibiotics or natural product antibiotics in such a relatively short period of time led to excessive use of drugs, and actually it contributed to emergence of resistance. So in this picture you can see the first antimicrobial drug salvarsan was discovered in 1910, and then 1987 daptomycin is the last class of antibiotic ever produced. What they do now when they talk about new antibiotics is they just add the side chain to increase the spectrum of that particular antibiotic. So there is no new group of antibiotic that has been produced after 1987, and that is scary. So let's talk about antibiotic resistant crisis. In this picture you can see on the bottom there is a date of discovery, on the top there is a date of resistance. So here you can see the pattern, around 5 years of uses. After 5 years of uses, most of the antibiotic, they have some form of resistance reported. This bacteria, they are smart. Antibiotic uses selects for the emergence of resistant organism, and then this emergence has outpaced the development of new antimicrobial, which is kind of scary. And there is no new antibiotic that has been developed after 1987. Causes of antibiotic resistance: overprescribing of antibiotics, patient not finishing their treatment, overuse of antibiotics in livestock and fish farming. Classical example includes tetracycline. Tetracycline does not work against enterococcus anymore. Then poor infection control in hospital and clinics, lack of hygiene and poor sanitation, lack of new antibiotics being developed. So we are running a race against time. So how do we deal with it? The solution includes limiting the use of antibiotics, because these bacteria, they are smart. If they get exposed, they will figure out how to become resistant. So if you notice the recent trend has been limiting the duration of treatment for almost all infections. And you might have seen antimicrobial stewardship team in every hospital. Another solution could be new technology. Things are not all gloomy. New antibiotic producing strain in explored environment, and there is a mRNA technology which has invigorated the natural product that was first described in 1930s. But these are the things for the future. But for now, limiting the uses of antibiotic is the best policy. Adverse effects of antibiotic uses is seen up to 20% patients, and it includes drug toxicity and antibiotic resistance. In 2013, CDC estimated 2 million infection and 23,000 deaths each year, and it has been predicted to go up to 10 million by 2050. That's a big number. All antibiotics have been associated with C. diff infection. I'll give you an example. 2005, 2006, people used to say C. diff will never get resistant to fluoroquinolones. And in 2020, fluoroquinolones are the #1 cause of C. diff infection. So, general reduction of antibiotic uses is the optimal approach to decrease the adverse effect of antibiotic uses. So let's discuss about factors affecting antibiotic selections. As you know, disease comes from interplay of three factors. That is, susceptible host, virulent pathogen, finding good environment. So disease occurs with the interplay of all these three factors. So whenever you are prescribing an antibiotics, first you have to ask yourself whether your patient is normal or abnormal host. And then you need to think about allergy and comorbidity, example, renal function, because it is going to affect the dose. Then you need to think about environment. What kind of infection you are trying to treat? Where was that infection acquired? Was it community acquired or hospital acquired? What makes that infection likely to be hospital acquired if they are recently hospitalized? And then you determine the likely organism based upon anatomic source, gram stain, or rapid test. Example, somebody coming with pneumonia, you send for MRSA-NAT. And then you determine likelihood of resistance. You need to know local susceptibility patterns. It's very important to know local antibiogram. Then you need to know known colonization. You need to look at the past cultures from the patient. And then you need to ask the recent antibiotic uses. Any use of antibiotic in the last 90 days makes the likelihood of resistant organism very likely. Then pathogen factors. How serious is the infection? How virulent is the organism? What is the chance of systemic infection including bacteremia? Then you think about antibiotics factors. What is the bioavailability in the infected site? Example, if you're trying to treat meningitis, is that antibiotic going to cross blood-brain barrier? Classical example, aminoglycoside. It does not penetrate blood-brain barrier. Then you need to think about broad or narrow spectrum, whether that antibiotic is bactericidal versus bacteriostatic. Bactericidal agents are preferred if somebody is really sick, if somebody has endocarditis, or if somebody has a neutropenic fever. In neutropenic fever, basically just confining the infection is not the way to go. These people, they don't have immunity, so you would like to give something that goes and kills the bacteria. And then use of bacteriostatic agent has not been proven to be beneficial in meningitis and osteomyelitis. That's why you'd like to use bactericidal agent. In infective endocarditis, if you look at the core of vegetation, let's say this is the core of vegetation, this is the vegetation, this is the core of vegetation. The bacteria here in the core, they are metabolically inactive and they are not multiplying. So, if you look at bactericidal agent, they are most effective in the log phase of the bacterial growth. So this is the lag phase and this is the log phase. This is the multiplication phase where bactericidal agents are effective. So basically in infective endocarditis, you would like to give bactericidal agent that goes and kind of kills the bacteria in the first touch, number one. Number two, you'd like to give bactericidal because it goes and kills the bacteria, and you'd like to give antibiotic for long duration. Why long duration? Because these bacteria, they are in the lag phase. So basically by giving antibiotic for long duration, you are essentially waiting for those bacteria to go into this log phase, all of them to go into log phase where that bactericidal antibiotic is effective. Then the third principle about infective endocarditis, you give antibiotics, antibiotics, IV antibiotics, because with IV antibiotics you are going to achieve the desired concentration. So these are the three principles of infective endocarditis management. So as we talked about, bactericidal agent is preferred for endocarditis, neutropenic fever, and meningitis and osteomyelitis. Then you think about side effect of antibiotics, and then also you need to think about side effect of that particular antibiotic with the current medicine that patient is already on. And remember, IV route is preferred in people who are critically sick or bacteremic or have infective endocarditis. So general principle is, if your patient is very sick or if your patient is immunocompromised, start covering broadly until you have some information about your pathogen. Then start with the broad, and then by day three, you need to have some information about the pathogen. What does that mean? The culture report is going to come back, the blood culture that you sent, or the culture, specific culture that you sent is going to come back. And then in sick patient and bacteremic patient, make sure patient is getting bactericidal antibiotics. And then it's not only, about writing the order. Be compulsive. It's your patient. Make sure they are actually getting the antibiotic that you prescribe. Every second counts. If your patient is bacteremic, leave everything else. Put the order in, go to the pharmacist, tell them that your patient is bacteremic and you want to give this antibiotic as soon as possible. Then go to the nurse and tell them that your patient is going to get this antibiotic. Would you mind paging me after you hang this antibiotic there? Every second counts. And remember, new is not always better. If there are several antibiotics with a similar coverage, select the one which is least expensive. That is going to improve the compliance. Then convert from IV to PO as soon as it is feasible and clinically indicated. Why? By day 3 you should have information. If nothing is growing in the culture, probably it's the time to stop antibiotic. If there is a clinical indication to continue antibiotics, probably it's the time to change from IV to PO. And this strategy has been shown to decrease the cost, but without compromising clinical outcomes. Remember to limit the duration to shortest appropriate time. So after this, let's talk a little bit about 4 moments of antibiotic decision making. This picture I got from Healthcare Research and Quality, US Department of Health and Human Services. So what are those 4 moments? Does my patient need antibiotics? Was culture done? Then what empiric antibiotic I should start? When you have those questions, think about syndrome and context. Then think about targeting key organism. Is that antibiotic going to work in the place where the infection is? If there is a serious infection, think about prescribing bactericidal agent, and never forget source control. Then number 3, can I narrow the antibiotics from IV to PO? Then what duration of antibiotic therapy is? So these are the 4 moments of antibiotic decision making, which reflects the same principle that we just talked about. Example of poor activity at the site of infection. Oral vancomycin is not absorbed. Similarly, IV vancomycin is not secreted into the gut in therapeutic concentration. So oral vancomycin you cannot use to treat systemic infection. IV vancomycin you cannot treat C. diff colitis. Cefazolin has a poor CNS penetration. So if you are trying to treat MSSA of brain, cefazolin is not a good choice. Cefazolin is a drug of choice for MSSA, bacteremia, but not if there is a concern about CNS infection. Then daptomycin is inactivated by pulmonary surfactant. Daptomycin causes eosinophilic pneumonia. So you cannot use to treat pneumonia. Micafungin does not get into urine. Moxifloxacin, azithromycin, they don't get into urine. So targeting key organism. Gram positive, what is the risk of MRSA? Gram negative, what is the risk of Pseudomonas? What is the risk of ESBL? What is the risk of carbapenem resistant organism? These are the questions you are going to ask. Anaerobe, what are the anaerobes you are trying to treat? Is it above diaphragm anaerobe? Is it below diaphragm anaerobe? Above diaphragm anaerobe, clindamycin, drug of choice. Below diaphragm anaerobe, metronidazole, drug of choice. Atypical, what is the risk of atypical bacteria? Whenever you have atypical organism, you cannot give antibiotics that works in the cell wall. Then what is the risk of tick-borne illnesses? And then fungal infection. Is there any risk factor for fungal infections? So classical example includes TPN. People on TPN, they tend to get fungal infections. Also people with immunosuppression, neutropenic people. After day 5, they are at risk of gram-negative sepsis. Let's talk about anaerobic coverage. Classic 2 antibiotics that cover anaerobic organisms are metronidazole, below diaphragm anaerobe, and clindamycin, above diaphragm anaerobe. When you combine penicillin with the beta-lactamase inhibitors, there are 2 properties that penicillin is going to get. The number 1 property is going to be anaerobic property. All right, so we are talking about this penicillin with the beta-lactamase inhibitors. So it covers anaerobic. Example, augmentin, covering for aspiration pneumonia. So if you are treating for aspiration pneumonia in the hospital, you want to send them home, you can probably give augmentin. So anaerobic coverage. And then the second property is MSSA property. Penicillin itself does not cover Staph aureus, but if you combine beta-lactamase, you get MSSA coverage. So these are the 2 properties. Then quinolones have some anaerobic coverage. Carbapenem, chloramphenicals are other antibiotic that have anaerobic coverage. Then atypical coverage, we're talking about bacteria that don't have cell wall. So macrolides. So classic example, community acquired pneumonia. You combine ceftriaxone with azithromycin. Why? It covers Legionella, Mycoplasma, and Chlamydia, 3 group of bacteria which can cause community acquired pneumonia. Then tetracycline is also used as a substitute for azithromycin in community acquired pneumonia because it also covers atypical organism. Tetracycline is considered broad spectrum for atypical coverage. So remember that. Quinolones also provide coverage against atypical organisms. So do chloramphenicals. So gram-negative coverage. So if you go higher up in cephalosporin, beyond 2nd generation, it covers gram-negative. Penicillin with a beta-lactamase inhibitor is going to cover gram-negative. In addition to these 2 antibiotics, quinolones, monobactam, Bactrim, carbapenems, which are most strong, aminoglycoside most strong, and chloramphenicol, which is rarely used, these also cover gram-negative. Remember, aminoglycoside is most strong, but it is limited by the fact that it's a polar substance. It does not act everywhere. It does not go to the lung and treat the pneumonia. You can treat cystic fibrosis with the bronchitis component, but the pneumonia component is not covered by aminoglycoside. Remember that. Whenever you are giving for cystic fibrosis, in addition to aminoglycoside, you have some beta-lactam antibiotic which covers for Pseudomonas when you are actually treating cystic fibrosis. Aminoglycoside, though it covers gram-negative, it cannot be used to treat meningitis, brain infection, and because it does not cross blood-brain barrier. So these are the limitations. And then antibiotic with excellent bioavailability. So these are the list. So the notable example I would like to give here is in the linezolid. Linezolid has almost 100% bioavailability. So you cannot really explain giving IV in linezolid in your patient unless your patient has a acute congestive heart failure and is not having good gastric mucosa to absorb linezolid. There is no valid explanation to give that antibiotic IV. So these are the different mechanisms of action of different antibiotics. So I'd like you to go over this when you have a time. And then use your resources. Use local antibiogram to guide antibiotics, empiric antibiotics. And then up-to-date John Hopkins guide is also very good resource as Sanford guide. So let's talk a little bit about MDRO, multi-drug resistant organism, which is defined as organism that is sensitive to two or fewer antibiotics. So MRSA, methicillin resistant Staph aureus, VRE, vancomycin resistant enterococcus, ESBL, that is extended spectrum beta lactamase, and then CRE, which is carbapenem resistant enterobacteriaceae. So these are the examples. Some of them have inherent resistance to most antibiotic. Classic example is Acinetobacter. It's hard to treat this infection. And then these infections, they require longer and costly treatment. And then that results in extended hospital stay and greater disability. And then good thing is several older antibiotic which has not been used for a while, they retain some some activity against this bug. So example include minocycline against Acinetobacter, and then also fosfomycin made a great comeback to treat some of these resistant organism when you have a UTI. But ID consultation should be considered whenever you are dealing with multi-drug resistant organisms. So this is the table that I got from Dr. Michael Stevens. So I hope he doesn't mind. So four core actions to fight MDRO include infection control practice, tracking resistant bacteria, which is done at the clinic level, it's done at the lab level. Whenever you see multi-drug resistant organism, they do surveillance activities. And then having antibiotic stewardship program in your hospital, which is very important. And then last but not the least is promoting the development of new antibiotics. These are the four core actions to fight against MDRO. This concludes part 1 of the lecture series. If you have any questions, don't forget to email me at spodel@mcw.edu. In part 2, I'll be talking about individual infections, and in part 3, I'm going to talk about individual antibiotics. Thanks for watching.